Hello, everyone, and thank you so much for joining us today. Not quite to the top of the hour yet, so I'll allow a couple more seconds for everyone to join us from the lobby. But again, thank you for joining us, and we're excited to get started. It is 2 o'clock, so we'll go ahead and get started today. Welcome to the Rural Health Executive Educational Series. I am Cody Smith, Partnership Manager with NRHA Service Corporation, and I'll be serving as your moderator for today's presentation. I am so sorry. I'm fighting this cold this week, and it's thrown me off. Before we dive in, please do note there's a short survey that will follow at the end of this session. If you could just take a few minutes and fill that out, we really appreciate it. Your feedback really helps us guide our future content to best serve your needs. A few housekeeping items. I would just like to say everybody is muted during the session to avoid background noise. We do aim to wrap up this presentation in about 45 minutes to allow some time at the end for the question and answer session. However, if you have a question at any time for our presenters, go ahead and type it into the question section of your webinar control panel, and we will be sure to address it. I'd also like to remind everyone this event is being recorded, and you will receive an email tomorrow with a link to the recording. Today, we have the privilege of hearing from Karsten Russell-Wood, Dr. Chandra, and Dr. Morgan as they present Bridging Gaps in Rural Health with the Telehealth Center of Excellence framework for Mississippi hospitals and beyond. Before we begin, I would like to extend our sincere thanks to our dedicated partner who enabled us to bring this presentation to you today, Equum Medical. We are so grateful for your continued support and all the industry expertise that you bring to the NRHA. You allow us to host conferences and educational webinars just like this and other events dedicated to improving rural health care. So again, thank you, Equum Medical. We truly value our partnership with you. Without further ado, I will turn it over for our feature presentation.
Cody, thank you very much. Let me begin by thanking you for the work that you put into making this such a great presentation, and to NRHA for bringing together the rural hospitals across the country that are inspired to collaborate and participate and learn to make sure that rural care is sustainable. For the audience, my name is Karsten Russell-Wood. I'm the Chief Marketing and Experience Officer at Equum Medical. And today I'm joined by Dr. William Morgan, the CEO of Copiah County Medical Center, and Dr. Saurabh Chandra, Chief Telehealth Officer of the University of Mississippi Medical Center. We'll be speaking about bridging gaps in rural health, the Telehealth Center of Excellence framework for Mississippi hospitals and beyond. I myself, my own personal story is, let's say for the past 2.5 years, I've been a student of rural health, not coming from a rural area to begin with, but now living in one, and not really understanding what the challenges of rural America and rural hospitals were. To that end, meeting Dr. Chandra, meeting Dr. Morgan, and learning from Dr. Skurlock, we've put together a primer that outlines not only the capabilities and promise of telehealth for rural America, but also practical examples how telehealth has helped keep care local and make sure care can be remained in rural communities. For today's webinar, we're going to balance this with a root understanding of telehealth, then move to learn a little bit more about the amazing journey that the University of Mississippi Medical Center has gone through to become one of only 2 of America's telehealth centers of excellence as designated by HRSA. That's just truly a remarkable achievement. And then we'll hear from the personal use cases and performance of a telehealth-enabled program, which is Copiah, and I think that's a wonderful story. And throughout, as Cody mentioned, we're really here today for this communal fireside chat to hear and share information. That's how we came together. I didn't know Dr. Morgan. I've known Dr. Chandra for a little bit, but really, if we wouldn't share our own opinions and thoughts and experiences, we ourselves couldn't actually improve. Maybe by sharing and observations about telehealth. And having been in the space of telehealth over 15 years, we really can look at it as three phases. As COVID stressed our health systems, both urban and rural, hospitals responded through what we call a panicked buying phase of telehealth solutions. And really the goal here was continuity of operations, ensuring there was availability and access to providers. Through COVID and as funding for COVID-related telehealth and technology investments shifted, hospitals realized that they could not continue to sustain multiple individual platforms of telehealth that weren't consolidated and weren't working together. It was more operationally inefficient than it actually was bringing value. And here's where health systems and hospitals went through an investment rationalization, focusing on making sure that a COVID-related single service line of telehealth, such as telecritical care or teleneurology or tele-ED, would be connected to other forms of telehealth through the organization, and ideally rationalized by streamlining the number of vendors that were serving that hospital. And now, with a tailwind of technology investment and adoption post-COVID and post-emerging state, we are beginning to see a future state of integrated virtual care. And here, truly, telehealth is becoming health. Telehealth is being modeled at the enterprise to connect the emergency department to discharge on the acute side, but truly make care venue-less and allow higher acuity patients to receive care anywhere through technology advancements and, of course, telehealth solutions. What's remarkable to me, as I began saying that I was a student, was many of the challenges that papers suggest rural communities have regarding distance, scarcity of labor, equity and specialist locations makes rural hospitals uniquely designed to capitalize on telehealth and digital health. Some of the reasons why, and I've noticed this being at NRHA meetings, is hospital administrators have a sense of urgency to respond. This is because from a financial standpoint and a sustainability standpoint, they need to be able to pivot fast and make the right decisions that support the hospital of their communities. Second, rural hospitals are remarkably forward-thinking and progressive relative to innovation. The goal, again, is try new things, allow those things to help solve problems that the community has. And lastly, as we're seeing here and experienced with Dr. Morgan and Dr. Chandler on the phone, there is a general sense of openness and collaboration to make sure rural hospitals across the country connect and help each other succeed. Now, today's webinar spotlights Mississippi. And as we look at Mississippi and learn about Mississippi, there are many demographic and environmental factors in Mississippi that make Mississippi unique for telehealth, and of course also the challenges magnified in Mississippi compared to other parts of the country. In fact, if we look at America and think 18% of the population lives in rural areas, in Mississippi that's over doubled, and we have nearly 50% of Mississippians living in a rural area. Of the counties in Mississippi, again, a majority are rural. And we see through this a continuous theme of access to care and equity in care delivery, as of course the doctors that are in Mississippi are practicing mainly in the urban areas in Mississippi and not distributed across the countryside. Now, I made that about Mississippi, but truthfully, those are the same problems that we face in every state across our country. And the questions that we partner with critical access hospital administrators on are questions like, how do we increase access to 24/7 care? Doesn't matter where it is. Second, what services do we need to keep local? And if we bring and retain specialist services locally, can we retain those patients here in the community versus transferring them? And lastly, of course, how can we help the providers that have made the choice to reside in rural communities more supported by giving them access to the specialist care that isn't available locally? Now, we see this across the US, and for the second year, American College of Health Executives has recorded through their annual survey that workforce shortages are the #1 reason hospital administrators are staying up at night. This is a chronic problem now. This is not a COVID problem. On the physician side, this problem is magnified not only by the amount of total physicians, but in fact, where the physicians are located from a metro or a non-metro area. And of course, the nursing shortage, especially thanks to burnout and COVID-related exhaustion, has been magnified. And again, we're seeing a shortage of the nurses all the way across the country, both in the urban and the non-urban areas. Now, if we think about the triple storm and we see that there aren't enough providers, and then we realize that, on the other hand, not having providers means that the patients can't remain local either, we see how a burden to care access is going to increasingly impact rural communities, as now these patients are leaving the rural community for care and potentially traveling further for care than ever before. And this means also that likely follow-up care is going to continue beyond the local community. With that background, I'd like to transition this to Dr. Chandra and welcome him to share a little bit about himself and then his remarkable journey at the Telehealth Center of Excellence at University of Mississippi. Dr. Chandra?
Thank you, Carsten. Can you hear me okay? All right. Well, good afternoon, everybody. I would like to start by thanking the National Rural Health Association for this wonderful opportunity to talk about our Center of Excellence and some of our experience in implementing innovative telehealth programs here in Mississippi. I also wanted to give a shout out to HRSA because the work that is being done by the Center of Excellence is through the grant funding made available by HRSA. And just wanted to point out that the content of my presentation is my own view and is not endorsed by HRSA or the U.S. government. So, I'm a critical care physician, and for now more than a decade, I have been a passionate proponent of telehealth as a valid modality of delivering healthcare. And my real journey in telehealth and tele-ICU started when I was recruited as the founding medical director of tele-ICU, an enterprise-wide telehealth for the largest health system in New York called Northwell Health. I was there for a number of years. I was there when the pandemic started and was instrumental in setting up the critical care response through telehealth for the health system. But as I was setting all those telehealth programs, mostly in urban areas, I wanted to move to a setting where I could show the real value for telehealth, and mainly in a rural area, in an underserved area, and I was fortunate enough to be hired by UMMC to lead the Center for Telehealth as Chief Telehealth Officer. Right during the pandemic, I moved from New York to Mississippi in August 2020, and so I had the kind of experience of overseeing the response, the first wave of pandemic in New York, and then moved here when Mississippi was experiencing their first round of COVID as well. And so I've been here for the last 3 years, and we have, and I'm thankful for partners like Dr. Morgan, who is the CEO of Equum Medical Center, and others and their belief and partnership, which has been very valuable in helping us set up some innovative telehealth programs throughout the state of Mississippi. For today's presentation, I'm going to talk and focus on some of the work that we're doing in bringing in critical care services to small rural hospitals. Because historically, the tele-critical care services, also known as tele-ICU services, has been predominantly, provided to large health systems in urban areas. And it has been one of my passions to bring it to smaller hospitals, to work with partners like Equum, who also are aligned in the vision that we have here at the Center for Telehealth, and enable that these, and the question is, why should these services just be available at urban areas in large health systems? Why not have smaller hospitals, get the benefit of these services? So that was the overall driving mission behind implementing this project at Copaya, and the success that we are seeing there is a driver for setting up this paradigm for other rural hospitals, not only in the state of Mississippi, but our hope is that it can be replicated at small rural hospitals throughout the country. Next slide, please. So just to give you our history of our Center for Telehealth here at UMMC, we have a very rich history in implementing innovative telehealth programs. We recognize the value of telehealth in delivering healthcare or delivering access to healthcare for rural communities in our state way back in the 1990s, when most of the country has not even heard of what telemedicine was all about. And so we started implementing our programs. A very successful program that I'm going to talk a bit about is the tele-emergency program that was started in early 2000s and now has been replicated elsewhere in the country. It's a very successful paradigm. And in 2013, we established our formal Center for Telehealth. Next slide, please. And in 2017, we were designated by HRSA, the Health Resources Service Administration, as one of the 2 centers of excellence for telehealth, the other being Medical University of South Carolina in South Carolina. And that allows us to implement innovative telehealth programs, not just in Mississippi, but throughout the country. And the first round of that funding ended in 2021, but we were lucky to be designated for the next 5 years till 2026 as a Center of Excellence for Telehealth. In 2022, we received a large grant funding from Mississippi Department of Education here, and through the support of that grant funding, we have now established one of the largest school-based telehealth programs in the state. And that program is providing free of cost urgent care and behavioral health services to 190,000 students in the state in 421 schools in the state. And next slide, please. So this slide is showing our role as a National Center of Excellence. And as I mentioned, our mission is to improve access to healthcare via telehealth services by implementing innovative programs and demonstrating the value by doing rigorous analysis and proving the clinical value as well as the impact on healthcare spending. As well as one of our mandates from HRSA is to, once you establish the best practices of innovative programs, then we should share our knowledge and best practices with other entities throughout the state. Next slide, please. So this slide is just showing our footprint across the state. We are embedded in all counties of Mississippi. We have a whole spectrum of telehealth projects, whether it's tele-emergency, school-based telehealth program, tele-behavioral health, tele-infectious disease, and UMMC to You, which provides direct-to-consumer services to patients in their home 24/7, 365 days in a year. Next slide, please. So, for the purposes of this presentation, we are going to talk about how we are improving access to healthcare via audio-video telehealth. And what I mean with that is that telehealth is not just restricted to one modality of direct audio-video telehealth. It also encompasses other asynchronous modes, just like store and forward, as well as other modalities like remote patient monitoring. But for our presentation today, we are focusing on one such modality of telehealth, which is direct live audio-video visit consultations to rural hospitals. Next slide, please. So before I talk about some of the other specialty consults, I wanted to mention one of our signature programs here, which is the tele-emergency program. Under this program, emergency physicians at UMMC, which is the only academic medical center in the state, they provide consultations to 20 critical access hospitals throughout the state of Mississippi. And what I mean by a critical access hospital, it is defined as a hospital which has 25 or less beds. And so they are very small hospitals, but still, during the pandemic and even after the pandemic, they have been many times taking care of patients which would benefit from extra set of eyes, would benefit from expertise that is not readily available at the bedside. So tele-emergency is one of that program in which, if at the critical access hospital, if their emergency department providers feel that they would benefit from a consultation from UMMC's emergency department physicians, then they reach out to us. We have established mobile carts there and a way of connecting to our providers. And whenever they have a patient that they feel would benefit from the consultation, they are connected to our providers, and our providers then give their recommendations and follow up with them. And this has been a very successful program. Next slide, please. And it has shown that there are reduced number of transfers from the rural hospitals to a higher level of care. So there are a lot of benefits. You have additional revenue that is can be kept by critical access hospitals. In addition to that, more importantly, it is really beneficial for the patients, because you can keep the patients in their local communities. And it has been shown that if you look at the overall cost of ED as a percentage of a total operating cost for the hospital, and there was a good study done by researchers at MUSC using our data, and they have compared hospitals that did not have the tele-emergency program versus hospitals that have the tele-emergency program, and they have shown that when they look at the cost incurred as a percentage of total operating expenses, there is lower annual ED cost that is incurred at hospitals that has this program. So it has multiple benefits, both from a financial standpoint, and with the current the risk of closure that is very high for rural hospitals. Such kind of programs have been shown to be beneficial for financial viability of these smaller hospitals. So this was when this was established, and this study was done in 2018. The idea was that just providing tele-emergency consultation is so beneficial, but those consultation is being provided in the emergency department. But what if we bring other specialties like critical care, nephrology, cardiology, neurology that is not readily available at these smaller hospitals? If we can add those, availability of those specialties through telehealth at these smaller hospitals, that could even be add on to the benefit that you are already seeing in the ED. So with that in mind, we decided to implement a couple of projects where we were bringing other specialties to these rural hospitals. Like these. So we started with a consultation at one of the rural hospitals. They had 2 neurologists. It's a South Central Regional Medical Center at Laurel, Mississippi. A mid-sized hospital, and they had 2 neurologists, and they unfortunately lost one of the neurologists. And so they had a choice, whether the choice was either shut down the service or turn to telehealth, because it takes a lot of time for rural hospitals to find and recruit specialists to come and work in rural areas. So they turned to us, and we set up this program where we train their nurse practitioners to work with remote neurologists at UMMC and facilitate presentation of the patients. So in this program, a mobile cart is taken from room to room. The nurse practitioner, on the other hand, facilitates the physical exam, presents the case, and then teleneurologists from UMMC provide consultations. It's a really cool program. For 15 days. The neurology service is provided by the neurologist who is available there at the bedside, and for 15 days it's done through telehealth. Next slide, please. And this is a data that we are showing for the first 6 months. There are more than 250 consultations were done, and I'm very happy to report that more consultations were done via teleneurology service, that's 138, then that were provided by the bedside team. The common diagnosis that they were seeing through these consultations were of stroke, post-stroke, epilepsy, and mental status changes. And 61% of teleneurology patients were discharged home with self-care or home health care. So the conclusion is that these kind of hybrid models, or models where specialty consultations can be provided to rural hospitals via telehealth, is very much feasible. And we are looking into capturing more data, and our analysis is, we are still completing our full analysis on delineating the true value of these programs, not just for clinical outcomes, but also from a financial return of investment perspective as well. Next slide, please. So after we successfully implemented this program, we talked about bringing critical care services, because when we met Dr. Morgan and others during some of our meetings, we came to know that yes, the pandemic has ended, but the problems are still there, and he's going to talk about from his perspective of what he's seeing at the small rural hospital. But I still remember him telling me, look, many times we have patients here who are awaiting transfer to the higher level of care, but we still need to do a good job in taking care of those patients while they're here. And not only that, many times we feel that if we have a consultation from appropriate specialists, we can manage those patients here, because I still remember him telling me that sometimes they have to send patients not only in other higher level of centers here in Mississippi, but they sometimes have to send patients to Louisiana, to Texas, only for the patients to be discharged in the next 2 or 3 days. Now, that is such a high burden for patient and their family members to just travel, go to another state, only to be discharged in a day or 2. So why can't we provide those kind of services? Why can't we enable and provide those kind of support for them to be able to take care of these patients and prevent unnecessary transfers to other hospitals which may be outside the state. So with that in mind, we implemented this what we call as a telecritical care service 24/7 at Copaya Medical Center. But here was the problem. There's a dearth of specialists. There's a dearth of primary care physicians as well as specialists in rural areas, rural states like Mississippi. And the question was, do we have enough bandwidth within the state to provide those services? And the answer was yes, but it may be difficult. So we actually then talked with Equum, and Equum has been providing critical care and other services throughout the country in multiple sites. They are aligned with our vision, and they also, our vision is, and we are aligned with our vision that smaller hospitals, especially in rural areas, should not be left behind and should also receive the benefit of telehealth. And so we said, let's partner and see what support we can provide to rural hospitals in Mississippi. And with that in mind, we established this program, and it is a very complex program. It's a very complex, complicated endeavor. We have to have all the Equum providers be licensed in Mississippi, credentialed in the state, get the credential in the hospital, have the privileges, and a lot of things have to be done to set up these kind of complex, complicated telehealth programs. But at the end of the day, when you see the results and when you hear from the bedside team, from the administration at these hospitals, it's worth, when you hear the good, the rewards, you feel like it's worth all the effort that goes into bringing these and implementing these programs. So we have implemented this program successfully at Copaya. We are now expanding that and implementing in the next 2 weeks in another hospital, Greenwood Lafleur Hospital in Lafleur County, which is the eastern edge of the Delta region of Mississippi. And that hospital has experienced a lot of difficulties. They have to actually close their full-fledged ICU. And our hope is that with the support that we will be providing them, they will be able to reopen a smaller ICU there and able to keep their patients from being transferred out of the community. Next slide, please. So anyway, this is our vision in a nutshell. And I think Equum, UMMC, the Center of Excellence, and our partners such as Dr. Morgan, we are all aligned in this vision that we need to develop an affordable model of providing specialty supports via telehealth to rural hospitals and build these long-lasting partnerships and connect. And of course, one of the challenges are how to connect different EMR hospitals with different EMRs. So our long-term vision is to create a system where we can enable a team of providers who can use a single platform to be connected to all of the rural hospitals and help improve the clinical outcomes in the state. I'm going to end there in my presentation and invite Dr. Morgan to talk about his experience. Thank you.
Well, thank you, Dr. Chandra. And I'll share a little bit about myself as we get into this presentation, so it'll make a little more sense as we walk through some of the slides. I am an internal medicine physician in the early part of my career, and I trained at the University of Mississippi Medical Center. And the hospital that Dr. Chandra referenced, Greenwood Lafleur Hospital in the Delta, is actually the hospital in which I was born. So certainly deep roots in Mississippi. However, after graduating medical school, I moved to Florida and practiced 25 years of internal medicine there. And that's where I originally got my experience in healthcare in terms of the administrative side of medicine. And in 2005, moved full-time into medical administration and being a physician executive. It was at a system in Florida named Health First, which was a 5-hospital system, where I first was exposed to telecritical care, if you would. We called it EICU back then. And Dr. James Schaefer introduced that program to our hospital, and we're one of the first hospitals in the country that had it actually present. So it was very enamored with it and how it worked. Although the model I'll describe is in my presentation is a little bit different than what we had there. And we'll point out some of those differences. In 2013, I moved from Florida to a larger health system in North Carolina named Cone Health System. And Cone at the time was about a 7-hospital system in multiple counties, 5 counties, I believe, and took over the leadership of a 750 physician medical group, and got quite exposed to various platforms of telehealth while at Cone Health. And it's there as I move deeper into my understanding of the complexity of putting some of these programs into place in the background. It was in 2018, kind of a serendipitous phone call to wish a previous colleague of mine happy birthday, that I was recruited to come to St. Dominic's Hospital in Mississippi. And having been away from Mississippi for many years, I felt the call to come back home. And I accepted the position to come back to St. Dominic's in Jackson as the Chief Clinical Officer, Chief Operating Officer, and was there for about 3.5 years. Shortly after the opportunity came, there was some turnover in the system after the system was merged with a system out of Louisiana. And 2 weeks after leaving St. Dominic's, I came to Copiah County Medical Center, and you see it pictured there on the slide. I initially told the board that recruited me there that I would be there for 6 months, and this June will be 3 years, and share a little bit about that as we go through why I'm still there. The opportunity that was presented to me was, though, that I would be able to look at Copiah County Medical Center and partner with UMMC and other, the ACO, the statewide ACO in the state of Mississippi, to use the medical center there to as kind of a proof of concept. How can we take different types of healthcare and spread it across the state to improve the healthcare in the county, rather within the state and within each county within Mississippi. Copiah County Medical Center, the hospital that we have this program embedded in, opened in 2017. However, it was the child of a larger hospital, which is now closed, named Hardy-Wilson Hospital. Hardy-Wilson, much like many rural hospitals in Mississippi, was aging, its services were failing, and probably the most famous thing that Hardy-Wilson was known for is about 3 years ago, they did a paranormal investigation there that was on that TV show that so many people watched because of the ghosts that supposedly lived in the basement there. But at any rate, in 2017, the hospital moved to Copiah County Medical Center, and that's where I started in June of 21. By definition, critical access hospitals are a 25-bed hospital. We do have a 9-bed emergency room. It is not part of the tele-emergency system that Dr. Chandra spoke of. We have physicians staffing that 24/7, and it is a member of the American Hospital Association, Mississippi Hospital Association, and recently got its accreditation this year, its reaccreditation. Copiah County Medical Center in the city of Hazelhurst, it sits about 39 miles south of Jackson. So that's kind of a good bad thing, in that the patients, when they do have to travel, it's not very far. The bad part is that the hospitals in Jackson are often poaching our staff, quite honestly, because we've not had that problem except when they usually migrate to Jackson because of the labor opportunities they see. But many of them do return home. In terms of the county, it's much like many rural counties. The average household income is $46,000 a year, whereas the national average is about $75,000. So certainly impoverished county. And that's why keep allowing people to stay home. Dr. Chandra alluded to it, allowing people to stay home and not have to travel is so important. That's what this project is all about. Next slide. So I like to call this kind of my Mississippi worldview. I've talked a little bit about being in North Carolina and being in Florida. And as I've shared, I did come home to Mississippi, to St. Dominic's, which is in Jackson, Mississippi. It's a 545-bed tertiary referral center. All of the hospitals I've worked in previously, either overseeing as an administrator, as an executive, or working as a clinician, were probably the smallest were 150, and as you see, several of them were 550 beds. While working in Jackson, what I learned, what I called on the receiving end, every winter there was the inability of our hospitals and all hospitals in Jackson to receive the demand that was being put upon it for transfers. And routinely, the hospitals, due to a number of factors, have anywhere from 25 to 50 patients in the emergency rooms waiting to be admitted to the hospital. So even if they, even if they wanted to accept our transfers from a rural hospital such as Copiah, they cannot. The capacity simply is not there many times. And hence, as Dr. Chandra alluded, many times patients are sent out of the state. When I moved to Copiah, which you see in the bottom right side of your slide, I was on what I call the sending end of the spectrum. And it was there that I saw the real needs of the small communities having to send patients out for numerous reasons, either the inpatient or the ED, and the stress that it put on the staff, the hospital, and the family members as they sat in the emergency room or in the hospital with their loved ones dying in front of them, and with us not being able to get them the care we need. We literally have sent patients from our hospital in Southwest Mississippi to Louisiana, to Texas, to Tennessee, to Alabama, and to Florida. And those diagnoses are everything from a dissecting thoracic aortic aneurysm that we could not get into a hospital 40 minutes away, to something as simple as an NSTEMI that, if we could have cared for and kept on the hospital overnight and discharged the next day. So the needs vary, but nonetheless, the transfers are amazing. And we do track our calls on the transfers, and it is many times we will call up to 25 institutions before we'll find an institution in the wintertime that will be able to take our patients. Certainly during COVID, it was all year long, and so that was an unusual stress. But even before and after COVID in the winters, we're finding the same problems. So I had the opportunity to meet Dr. Chandra through a friend, Dr. Dan Jones, who was previously Vice Chancellor at UMMC and the Chancellor of University of Mississippi, the university itself. He lives in Hazelhurst, and he's been a great supporter of everything we're doing. And just a shout out to Dr. Jones. But it was there that we had the opportunity to discuss the ICU program. And if we'll go to the next slide. And we probably started this conversation a year and a half ago, Dr. Chandra, I suspect it, and dealing with HRSA, dealing with the Higher Institutes of Learning, and a number of other things. He used the word complex. It's a complex process. I would say we need to capitalize the C in the word complex, because it truly was challenging getting started between getting it through the legal system and all the agencies. But now that we kind of got it down to where we needed it to be, we're really up and running well. We originally talked about, with our early plans, of having a model very similar to what I experienced in Florida, where we had dedicated rooms. We were going to dedicate 2 ICU rooms, but we've basically moved now into a model where we have a kind of a rapid robot model where we take the ICU to the patient in their room, and that alleviates the need to have patients move from one room to another or have dedicated rooms. So the logistics have changed as we've gone through this a little bit, as we looked at it. Likewise, the scope, we initially said this was going to truly be a tele-ICU model. And that kind of scared our nurses and scared some of our providers. And so we kind of relanguaged it and said, look, if we have a patient that needs a higher level of care, if it's a higher level of acute care that is needed, let's use this project. And in doing so, we spread our scope, but it also increased our scale. We were now able to get more consults into the process, and to be able to track some value by doing so. We also looked at initially that this was going to be a provider triggered or activated program, if you would. We learned, however, that probably created some delays, and with our hospitalists that we have, they're not there in the nighttime program, so that was creating some delays. So now we have it where this can be activated by the nurse at the bedside. And then we also are looking at some reflex activations in the emergency room for certain diagnosis, so that we can get the telecritical care doctors online quicker at the beginning of the care, so they'll have a better appreciation, help guide us through the care. In terms of the services that we're providing, we're using it in the emergency room to stabilize our patients. As we said, we often have times getting them out of the hospital, so we'll stabilize them. If we do have a patient that might qualify for admission and we're just not sure about it, then the program is set up that the ED doctor, an Equum provider, and our hospitalist will actually have a joint conference and decide, yes, we can keep this patient in our hospital, or no, we think we need to go ahead and transfer the patient. So we're obviously not putting every ICU patient into our hospital, but those that are appropriate after joint conferencing, we will put into the hospital to be monitored in this program and to be followed by the critical care physicians. On the inpatient side, likewise, whether it's a heart failure patient or whether it's a patient who might be having a stroke, patient who has a sudden deterioration in blood pressure, whatever it might be, the activation occurs on the inpatient side. Many times that patient is stabilized there, and sometimes it does call for a consult, rather a transfer to be done. But again, we've got the provider oversight to guide the therapy just as if they were in one of the hospitals in Jackson. So the ED doctors, I would say, are a little slower to adopt it than our hospitalists are. But we've had some recent conversations. They didn't quite understand the value. They were afraid they were becoming an intensivist themselves and taking on the risk of being an intensivist. And when they really understood that this was an overlay to what they were doing and a support, they got much more comfortable. And hence some of these processes are now evolving how they get involved with this. On the inpatient side, we have moved to a hospitalist model where we have got nurse practitioners running our hospitalist program. Of our 6 physicians that are on staff, 4 of the physicians are over 65 years old. So obviously they don't really have a whole lot of interest anymore in coming into the hospital to do admissions. So we have moved that into a hospitalist model with nurse practitioners. The nurses initially required some kind of hand holding to make sure they were comfortable. They weren't used to taking care of this critical ER patient, and nor were the ER nurses. They're like, let's check them out and send them out. But now as they've kind of gotten comfortable with this, the nursing morale has really improved. They see that they are able to kind of practice what they were trained to do. They feel like they have the oversight that's needed so our patients will get the top-notch care they need. And they don't feel like keeping them there or a disservice. And they have confidence when working with the ICU doctors as they evaluate the patients that the decision whether they can stay or be transferred out is being done as a team approach rather than just a physician or provider kind of having to make that decision on their own. But likewise, the provider confidence, as I mentioned, we have a hospitalist program with nurse practitioners. They do have overseeing, obviously, family practice physicians, that they're collaborating physicians and the medical director of the hospital, but they're off-site. Those physicians are off-site and are telephone call. So this really gave them greater confidence in having oversight and making the right decisions, or just having the decision they've made affirmed. And then finally, I would say that our patients, one of the things we saw week 1 was that the Equum providers, the compassion, they obviously have good training and are good people, because both our nurse practitioners and our patients had nothing but very positive things to say about the providers who were looking at them from the other side of the camera. And so that's a real key piece I think everybody appreciates and understands. Next slide. In terms of, I mentioned current state. Additionally, we have in place telestroke. Dr. Chandra alluded to that a minute ago. So that's the second piece we have. We are working with UMMC to apply for another, I believe, HRSA grant to put in telemental health within our county, and this would be embedded within our outpatient services. And we are working with UMMC with the cardiology program about a telecardiology program, with that focus initially being primarily on how do we keep in STEMIs and what protocols do we use to overnight these patients with mild bumps and troponins, and really who are clinically stable, that we might just evaluate them there, their nuclear stress or whatever it might be, and then determine do they need inpatient intervention or can they be followed up as an outpatient. Other opportunities we're looking at this month actually are telenephrology, and that is using telenephrologists to look at patients using home hemodialysis machines to dialyze those patients on the inpatient setting with telenephrology oversight. And Dr. Chandra and I believe we have a meeting on the 21st to kind of talk about next steps, what that looks like, and I'll get to tour the Telecenter of Health Excellence there in Jackson and Ridgeland. And so more to come on that. But one last piece on this, for those of you in rural hospitals, I would add that this is a recruiting tool. Karsten talked earlier about, or Dr. Chandra about getting physicians to come to rural communities. Certainly without specialty care in a rural community, the primary care doctors are less likely to come. So the more of these programs we can build to support health in our rural communities with specialists, telehealth, I think the more successful we'll all be in recruiting young physicians to join us in our rural communities. So with that, I'll turn it back over to Karsten, and thank you for your time and attention.
Dr. Morgan, thank you. Dr. Chandra, thank you. As I listen to how you came to Mississippi, it reminds me of Dr. Schaefer, Luann Torelli, some of the, over a quarter century of telehealth innovation they've done at Health First. And Dr. Chandra, the work up in New York and Northwell, innovating different projects in telehealth. What we really see is telehealth is a tool, and how you apply that tool to help care, however you want to do it across the healthcare continuum, really is where care is headed. We heard a few central themes, and one of them is making sure the right provider is in the right place at the right time. And if those providers are going to Jackson, if those providers are not even in Jackson, telehealth and through a dynamic model of virtual resourcing can bring those providers with it. And that's where really digital health and telehealth comes in. When we look at different models of telehealth, as we saw in the chronicle from Dr. Chandra, models of telehealth have now leapfrogged earlier designs of centralized capacity, which has made it more flexible and modular. And I think that really can help hospitals of different sizes get the right solutions that they need. And then to Dr. Morgan, your point, after you have one proof of concept that's validated and growing, you can add other solutions. And really then we have a virtual care roadmap for a hospital. Across the storyline, what we see is telehealth can be inserted as a parallel structure to the bedside care from the ED to discharge. Solutions in tele-ED, multi-specialty, even transfer benefit and critical care and high acuity. But then now tackling the downstream patient flow to optimize discharge on time with virtual nursing, telemetry, and of course, safety sitting or virtual sitting. Again, when we wrap this up, what we're hearing is how can telehealth not just help in one area, but how can it help the concept of a hospital system? And that system revolves around moving a patient through to optimize the discharge process, optimize staff utilization, and optimize efficiency. So we heard stories about tele-ED, removing pressure from the emergency staff that either may need a higher acuity specialist that's not on site or balance surge. Of course, try and maintain patients locally. And lastly, of course, support the effectiveness and the efficiency of our network of rural hospitals across the country. I want to thank you very much, first to NRHA and second to the wonderful stories from Dr. Morgan and Dr. Chandra that inspire us to realize that we can keep care local. Cody, I see a few questions have come into the chat, realizing we have the cutoff. If you would read off a few so we can get Dr. Chandra and Dr. Morgan involved.
Okay, yeah, let's get started here. We got a couple minutes, so if you do have questions, go ahead and put those in the panel at any time. Again, I apologize if I cut out a little bit. I'm doing my best to talk here. Can you describe some of the specific telehealth frameworks that have been successful in rural Mississippi and how these might be adapted to other rural areas nationwide? Dr. Chandra, if you'd like to start.
Yeah, absolutely. So one of the framework that I talked about is the tele-emergency program that we are providing to critical access hospitals. We talked about the specialty care audio video program that we just talked about, but there are other frameworks, and one of the framework that we are looking into and that can be replicated elsewhere in rural areas is the provider to provider, which is the e-consult, which is an asynchronous framework where instead of having live audio video visits, providers can electronically send clinical information to specialists, and they can send their recommendation back. The turnaround time is a little longer, and we are in the process of implementing the provider to provider consultations here in Mississippi, and hopefully we'll be able to share some of the data in the next year or so. Another thing that is very, very beneficial for states like Mississippi and the population that has high burden of chronic diseases like hypertension and diabetes is remote patient monitoring, which can capture data from patients who are living in rural areas and enable us to get their data directly at our center, and then our team can work with the patients in remote areas to help manage their chronic diseases while they are at home and enabling them, wherever they are. Cody, back to you.
Well, thank you. Another question, Dr. Morgan. What are some of the challenges you've encountered while implementing telehealth solutions, and how have you overcome them?
Well, I think it's the provider adoption, and the best way to, I think, overcome these challenges, whether it was our nurses or our providers, or get the people in the room. So one of the blessings of being close to Jackson and working with Dr. Chandra and Dr. Wilhelm is they have been so accommodating. Even Dr. Skurlock, who can't be with us today, he actually came down to Copiah and came down and saw the facility, met the providers, met the nurses. And so the adoption, whether it was the nurse educators coming down to meet with our nurses and just kind of getting them comfortable with it and just making those face-to-face relationships. And then just with the ED doctors, it was just this last week that Dr. Wilhelm came down to talk to one of our ED physicians who probably works the majority of, he has the most shifts of any of our ED docs, to come down and sit to talk to him, to get him comfortable, to kind of form that relationship and let him understand that this is not about overseeing what he's doing. It's just how can we help you? And so I think the key is getting back people to people when you have obstacles and let them kind of see what they have in common and what the goal is, and not just have it. We unfortunately get too technical in our communication today.
Yeah, great, thank you. I know we only have 2 minutes left. I'm going to ask one more question for you, Dr. Morgan, and then I want everybody to know, even if we don't get to your question, go ahead and put them in that panel now. I'll make sure the team knows that you have some questions and they can reach out to you. I also know there's been some requests for slides and all that. Remember, there is a link to the recording coming tomorrow, but I will make sure that the team gets that contact information as well. Dr. Morgan, could you discuss the role of patient and provider education in the adoption of telehealth services in rural communities? And how do you ensure ongoing engagement and trust?
Well, it's interesting you mentioned trust. Our vision statement, not our mission, vision is to be the most trusted source of healthcare in Copiah County. So trust is so important. And I think that gets back to the providers being comfortable and confident with what we're doing. And it's not what they tell the patient, it's the body language and the way they embrace it. They see their comfort, they see how they're working with the providers on the phone. And then it gets back to the compassion of the providers. They're not just looking at their medical problem, but they're actually there, making sure the patient is comfortable and asking questions that engage the patient in what's going on. So I think, again, it gets back to the way in which it's implemented. You don't put it just on the technical piece. You put it on this as a tool to connect people who wish to care for you.
That's great. Thank you so much. I'm going to just say some quick words and I'll turn it over to you, Karsten, to close this out. But thank you, everybody, for joining us today. Thank you, Dr. Morgan. Thank you, Dr. Chandra, for all the information. Everything you've shared today, I've got lots of great comments about how everybody was thrilled with what you had to say. So I'm sure there'll be lots of outreach after. Karsten, thank you so much for standing in for Dr. Skurlock. Please give him our best wishes in his recovery. Remember, everybody, there will be a link to the recording, and don't forget to take care of that session or that survey at the end of this session. Karsten, I'll turn it over to you to close us out.
Thank you so much. You have listened to Bridging Gaps in Rural Health with the Telehealth Center of Excellence framework for Mississippi hospitals and beyond. The call to action is, let's make this beyond Mississippi. Let's keep growing the innovation in rural health to make sure we can keep care local. Thank you very much.
Thank you, everybody. Have a wonderful day.
Thank you.